Assistant Professor Dr. DONIA also from Mansoura University. She will be speaking about T1 and T2 mapping in cardiac MRI clinical applications.
Thank you. So I will talk about the mapping technique T1 and T2 and your clinical applications. So as we know that MRI is the standard method for calculation of ventricular volume and function. It is the most accurate, and MRI is unique in its tissue characterization property by late gadolinium enhancement. And as we know that we can use the scar pattern in delineation or determination of what is the specific disease. But what is missing is that sometimes when the fibrosis is diffuse process, we cannot detect the pathology of the myocardium, and it's mainly because that we use the normal myocardium as a reference standard to the area of disease. The other thing is that in patients in whom we cannot give contrast, like in patients with chronic renal failure, contrast is contraindicated, so mapping is an alternative technique in this situation. So I will just first explain the pathology of myocardial fibrosis. So we have two mechanisms. The first is myocyte loss, where the myocytes are diseased and it causes fibroblast activation, and the area where the myocardium is lost is replaced by fibrosis. So this is what's called replacement fibrosis. The other pathway is the fibroblast activation, and this can occur in perivascular location, like in patients with diabetes, hypertension, or volume or pressure overload. The other pathway is interstitial fibrosis, where there is proliferation of the fibroblastic activity between the myocytes. And this can happen in patients with amyloid or infiltrative diseases. And it eventually ends by some sort of replacement fibrosis as well. So replacement fibrosis occur mainly in myocardial infarction, and interstitial fibrosis, as we know, it can occur here in hypertension, diabetes, or in this pathway as in amyloid or infiltrative diseases. So what is the T1 map? To understand the idea behind it, each tissue has its own value has its own T1 value. And we code this pixel by pixel to draw this image. So if we look here, this is the myocardium. It appears as green, the blood appears as red, and fat appears as blue. And this map, it can have different colors based on the vendor, and the colors can be changed. But the idea is that each tissue has its own value. So T1 map is a sensitive test, it's reproducible, and it can give us specific numbers. There are different sequences that we can use. I'm not going to go through the physics behind it. So how we do it? So we usually run this sequence, one before giving contrast and another time 15 minutes after contrast. This is called the native T1 mapping. We do it at 3 levels, basal, mid, and apical level. We can also do it in the 4-chamber plane, and we repeat the same thing after contrast. The other value that we get is the ECV. ECV is a way that we can quantify the volume of interstitium. And it has high agreement with the pathology. It also has some prognostic values. ECV is important in diseases like amyloid or infiltrative diseases, or any disease that cause increase and expansion of the interstitium. To get the ECV, we do it through this equation. So as you see here, we need the hematocrit value, we need the native T1 value, and we need the post-contrast value. We put them in this equation to get the ECV. So we can do the interpretation by two methods. First is qualitative. So we get this map. We see this area, this is the normal myocardium, and this is the diseased myocardium. See how it has this different color? You can compare it with the scale. So this is here like around 900, 960 is the normal myocardium. The red areas are the areas where the T1 value is increased, and if it decreases, the abnormal areas will show up as these colors. So this is the quantitative. So we have quantitative and qualitative method. This is how we quantify it. We can draw an ROI at any place if we want to see the value at a specific spot. Or another thing is that we can get the mean value. To do it, it depends on which type of software that you have. We can draw different ROIs, and we can average them to get its mean value. We also need to draw another ROI at the blood pool. Actually, the ROI need to be a bit bigger. And we draw the same thing in the post-contrast images. We can do this at basal, mid, and apical levels. And at the end, we use the equation to get the ECV. There are also different sequences for the T2 mapping. For us, we use this one at our scanner, which is a GRACE technique. The processing is similar to T1, and this is another way for processing. You can use it for T1 or T2, depending on which software you have. We can draw contour the endocardium and contour the epicardium, and the machine will give you the global and the segmental values like this. So we have like here we have like a kind of global value, and if you want to check a specific area, you can get it from here. And same thing with T2, it can give you these color maps. So what is the value of the T2 mapping? T2 mapping will usually increase if there is myocardial edema or myocardial necrosis, like myocardial infarction, myocarditis, sarcoidosis, or graft rejection. And mapping is now part of the clinical practice. It's not only a research tool. This is the updated protocols for 2020. And if we look at the protocoling, you can find the mapping in cardiomyopathies, either like sarcoid, myocarditis, dilated, hypertrophic, infiltrative. You can find the mapping in all these. And we usually compare the values that we have with normal values which are published, but the best thing is that you can have your own normal values from your scanner. If you don't have them, so having control on your scanner is the best. But if you don't have them, you can use the reference ranges. But an important thing is that you use a scanner that, like the one you're using, if you're using 1.5 or 3, and check the vendors that you have, which one, and the techniques that you do it, and you can use this reference values. And here we have the upper and lower limits. Just to note, that 3 Tesla scanner have usually higher native T1 values. Same thing here for T2, just check which technique you're using, which scanner, to get the mean values. I'm just going to show some cases for the clinical application. So we have, for the T1 mapping, the diseases that cause increase in the T1 mapping are amyloid, myocarditis, hypertrophic dilated cardiomyopathies, and the diseases that cause decrease in T1 mapping are the iron overload or the fat deposition. Fat deposition either in Fabry or in chronic myocarditis, where you have this fatty metaplasia. So if we look here, this is a case of myocarditis. This is the T2 weighted image. We see some areas of increased signal. This is the T2 mapping. So always check this scale. So we see in some areas that the color is like here. So it has increased values, and it corresponds to the areas of edema, and correspond to the areas of late gadolinium enhancement. Same here for the ECV. We see some areas of elevation in the ECV, which correspond to late gadolinium enhancement areas. T1 mapping also increased in cases of myocarditis, and if we look here at this ROC curve, we will find that it's even more sensitive than the T2. So this is here the T2, and this is the blue is the late gadolinium. This is the T1 map, and we see how it's more sensitive even. And because of their added value, they were implemented. As we know, the Lake-Lewis criteria is the criteria that we use for diagnosing myocarditis. And before, it included just the T2. And the updated criteria, now we can see the T1 and T2 added in it. So another value for using T1 and T2 mapping is follow-up. It can monitor, so the values will get normalized or improved when we follow up these patients. This is a case of myocardial infarction here. We see this stair image. We see here edema, and on T2 we see the elevation of T2 value corresponding to late gadolinium enhancement. T1 as well increase in myocardial infarction. We see here this is the T2 edema and late gadolinium enhancement, and increase in T1 mapping at the same area. Sarcoidosis can cause increase in T2 mapping. We see here this area of late gadolinium enhancement, and if we look here, we see elevation in T2 value. Takotsubo, even in the patient doesn't have any delayed gadolinium enhancement, but we see elevation in T1 mapping. This is one of our cases. We see HOCM, we see thickening of the apex with elevation of the T1 values corresponding to areas of delayed gadolinium enhancement. And so moving to HOCM, to hypertrophic cardiomyopathy, and these cases are frequently tricky where you cannot tell if it's HOCM or infiltrative disease. We see here diffuse subendocardial enhancement and corresponding elevation in T1 mapping. Same thing. So moving to the other end of the spectrum, Fabry disease, which causes decrease in T1 mapping. If we look at this case here, we see this blue color. So it's decrease in the T1 mapping value. This corresponds to it's a storage disease with lipid deposition. And this is how we can differentiate it from usual hypertrophic cardiomyopathy. And we see in Fabry areas of fibrosis with elevation of T1 mapping. So you can find both, but usually in the septum, you will find the T1 values for the mapping decreased.
DONIA, can we conclude?
خلصت تقريبا. Just in here, this is a case of iron overload. We see here, this is the T2 star values decreased. This is patient with mild, moderate, and severe iron overload. And if we look at the mapping, we see how in severe iron overload, it's the T1 value is markedly decreased. So I will close by this. So just remember that the diseases that cause increase in T1 mapping, edema, protein deposition, fibrosis, and decrease in lipid and iron overload, and it extended the ability of CMR to characterize the myocardium. Thank you.
Thank you very much, DONIA, for the presentation, and we move now to the last but not least